Welcome you all to Caracon 2023. It's nice to see some people in the hall early in the morning because it's a little cold and there's a little bit of fog, and I hope we'll have a fruitful session. We have a very esteemed panel and speakers with us, and so there's Dr. Vishal Jhanji, Dr. Sanjay Patel, Dr. Bhaskar Srinivasan, Dr. Rashmi Deshmukh, Dr. Mona Bhargav, and myself. The speakers will be introduced along the session, and we'll, I think, start right away with this session with the corneal imaging because it's such an important tool and an aid in our clinical diagnosis and managing the patients. And Dr. Rashmi Deshmukh will be moderating this session.
Thank you, Dr. Chintan. So to start off the session, the first talk is going to be given by Dr. Mona Bhargav. Each talk is going to be for 12 minutes, and after each two talks, we will have a discussion. So the first talk is on ASOCT imaging in corneal pathologies, and it is going to be a case-based discussion. Dr. Mona.
A very good evening to everyone. I would like to thank Dr. Nair for the invite and Kiracon for the opportunity to be here. I am going to talk on ASOCT imaging in corneal pathologies. So, with the advent of dynamic non-invasive corneal assessment technologies, ultra-high resolution cross-sectional imaging of the entire anterior segment 360 degrees is possible with ease. It's showing here. Yeah. So it works on the principle of Michelson's interferometer, where a reference beam of infrared rays is used to measure the delay in intensity of reflected light from various tissue structures. The reflected light forms an interference pattern, and the combination of these interference patterns thereby create a cross-sectional image of the tissue of interest. With the transition from time domain OCT to spectral domain OCT, devices have facilitated faster scanning speeds, greater tissue penetrance, and high axial resolution due to shorter wavelength of light. So we'll be focusing on the layer-wise imaging of the entire anterior segment starting from epithelium onwards, wherein the depth of involvement in cases of pterygium, scar, dermoid or chemical injury and OSSN, the characteristics of epithelium in RECE and keratoconus, thereby moving on to the posterior surface where DM characteristics, the DM breach, hyperreflectivity, breaks, protuberances, and the posterior surface of PK graft, host bed in LSLK, cysts in the cornea as well as iris cyst, breaching of DM and the presence of anterior chamber and deep corneal foreign bodies, and imaging of the entire corneal surface in dystrophies and post-keratoplasty ectasia. So moving on to each one of them one by one, herein we see a wedge-shaped hyperreflective area of pterygium, and there is an increased risk of corneal scarring with flat bridging interface transition, reduced apical head thickness, and disrupted Bowman's membrane as we see here. To determine the need of lamellar procedures depending on the depth of stromal involvement in both these scenarios, as well as the peripheral to central corneal thickness bed in Fuchs endothelial dystrophy. Dermoid depth, stromal invasion to decide for the need of amniotic membrane versus lamellar procedures depending on the invasion present. To ascertain the residual bed thickness after removal of fibrovascular pannus here in chemical injury to decide for the need of lamellar procedures along with the slit. A clear visible plane of separation with epithelial hyperreflectivity seen here in OSSN, which is all characteristics of non-invasive OSSN and helps us to differentiate from the invasive one. The presence of contiguous and confluent guttae involving only the epithelium layer and not the stroma, which is a characteristic of reticular epithelial corneal edema from Rho kinase inhibitors and classically gets resolved after stopping the drug. Donut-shaped area of epithelial thinning surrounded by the thickness of epithelium, classically seen in advanced keratoconus in the paracentral region. Here again we see an area of hyperreflectivity followed by backshadowing, which is classical of iron or metallic foreign body seen in a Lassick flap with a crater at the top. This is in spectral domain OCT, and herein we can differentiate between the microstriae from macrostriae in swept source OCT, where a longer wavelength of light can finally delineate the corneal boundaries, which less of distortion. Flap thickness and diameter, which can be accurately measured in this high resolution scans. Descemet membrane detachment seen after cataract surgery can be delineated here, which was managed by descemetopexy with resolved DMD. And here a capsular tag can be a mimicker. The posterior surface of the penetrating keratoplasty graft for looking at the irregularities present to decide for the type of endothelial keratoplasty procedure. Here, interface fluid and separation seen, which is more easily delineated in ASOCT scans with host bed separation with intact graft host junction, which resolved after compression sutures and descemetopexy. Here again we see a vertical scan imaging, which is advantageous over the horizontal scan. With a short video presentation, we will go through it.
The hyperreflective hair strand precisely just overlaid and followed the Descemet's arc, breach could not be determined with certainty. Vertical scans were done in the direction perpendicular to the orientation of the hair, along the entire horizontal length of the hair, starting from temporal and ending onto the nasal side of the hair, as seen by the green moving arrow. On vertical scans, the hair appeared as a hyperreflective small dot. This hyperreflective dot appeared in the posterior stroma just above the decimals. It gradually progressed posteriorly, nearing the Descemet's membrane. Finally, it breaches the Descemet's membrane and enters into the anterior chamber. Thus, breach of the Descemet's by the CT tip was clearly shown in the vertical scans of ASOCT, which was difficult to delineate in the horizontal scan.
Here we see an area of DM separation which increased to a DMD and resolved at 2 weeks interval. This mimicked actually a DMEG graft caused by inadvertent stromal staining during cataract surgery. ASOCT showing the graft separation, it can easily delineate interface fluid, orientation of the graft, graft thickness and graft adherence, and even the subclinical edema, and has a high diagnostic value. The hyperreflectivity of Descemet's, which can easily be an factor to differentiate between performing a non-stripping versus stripping DMEG. An area of epithelial edema, stromal clefts, Descemet membrane detachment can be made out with ease to finally decide for the management options in a hydrops. Here we see prominent protuberances with a high DM hyperreflectivity in a case of congenital glaucoma, which can be easily confused with posterior polymorphous dystrophy. Again, there is a cyst in a congenital cyst in a child with hyperreflective echos, which reduced spontaneously to a redundant cyst here, and there was a spontaneous, it recurred without any causative factors. Here we see a secondary iris cyst with showing hyperreflectivity and hollow areas of a multilobulated cyst. Anterior segment OCT showing a hyporeflective center and a hyperreflective margin, classical of a glass foreign body in the anterior chamber and in the stroma. A metallic foreign body with a classical hyperreflective margin and posterior shadowing effects causing a mirror imaging, which is again classical of metallic foreign body. Here we see a child with again a hyperreflective margin, anterior margin and posterior shadowing with DM breach shown by DM curling inside in a child with graphite injury. Central to peripheral corneal thickness is quite variable here with a thinning at the graft-host junction, which is characteristically seen in ectasia status post keratoplasty. Here there are various deposits involving multiple layers of the cornea and even the descemet membranes to decide for the type of keratoplasty procedure. So to conclude, ASOCT is a rapid evolving imaging which provides good illustration of the extent and location-wise involvement of different layers of the cornea as we move from epithelium to endothelium. It helps us in providing non-invasive diagnosis of OSSN with 100% specificity and differentiating it from pterygium. It plays an important role for treatment initiation, monitoring the response to treatment, preventing premature termination and recurrences. Deep corneal and anterior chamber foreign bodies, AC penetration, DM breach, defining the type of foreign bodies and the need for removal along with the best suitable approach can be easily delineated here. Configuration of DM and DMD, posterior surface of PK, host bed dehiscence, as we saw during the entire course of presentation, can be made out with ease with this indispensable tool. Thank you.
Thank you, Dr. Mona. As discussed, we'll have the second talk as well, and then we'll have discussion or questions for both the talks together. So the second talk will be on corneal imaging in microbial keratitis by Dr. Chintan Malhotra. She's the professor in cornea, cataract and refractive services at PGI Chandigarh. Dr. Chintan.
Thank you, Rashmi. And again, a good morning to all those who've joined later. So I'll be speaking about corneal imaging in microbial keratitis, one part of which will cover the ASOCT, of course. So we know that the cornea is the window to the eye. The eye is the window to the body, the cornea is the window to the eye, and corneal imaging is a window to that window. And anterior segment OCT and in vivo confocal microscopy are the main modalities of clinical utility for imaging in microbial keratitis. Now, what we need to understand is that ASOCT tells us the structural changes predominantly, whereas the confocal microscopy in most cases guides us to the etiology in addition to the structural changes as well. So there have been some patterns which have been described on ASOCT for microbial keratitis, which I think anytime we get patients of ulcers or keratitis imaged, we see them intuitively. But just as a quick recap, so if we see a hyperreflective lesion, it may be an infiltrate or a scar. A corneal edema presents as increase in thickness or loss of posterior convexity. Plaques either on the epithelium or the endothelium appear as, again, hyperreflective lesions, and if they are punctate lesions, then they appear pinpoint. Cystic spaces which have been associated with advanced bacterial or fungal keratitis are seen as hypolucent areas. One may see fibrin in the anterior chamber in association with retrocorneal plaques, and one may have stromal thinning and necrosis, which in fact gives us a very good idea of the extent of damage, because sometimes it's not possible to assess that in a very dense infiltrate where your light is not able to penetrate. But like I mentioned, these patterns are not specific to any particular microorganism. So ASOCT basically complements the slit lamp microscopy, and it provides supplementary information for assessing disease severity and monitoring. So what I mentioned earlier, to differentiate between corneal scars and infiltrates, both are hyperreflective, but as we know intuitively, infiltrates will be ill-defined with round borders and the overlying epithelium will either be absent or opaque. Whereas in the corneal scar, we'll have well-defined sharp edges, and the epithelium, because it's grown over the scar, will be normal. It might be thick, but it will be clear. So one place which contradicts what I said, it just tells us about structure. This is one example. I mean, this was what this paper has shown, that sometimes ASOCT may help us to guide a little bit about the etiology, although I won't say that this is 100% true. So looking at the characteristic of the retrocorneal plaque, if the plaque has irregular borders, despite the fact that the demarcation between the plaque and the endothelium is clear or not clear, it probably points, in this paper at least, to a fungal etiology, because we know in fungi, the fungal keratitis, the plaque is because of the hyphae penetrating the Descemet's membrane. On the other hand, the authors show that in bacterial and herpetic keratouveitis, there was a clear demarcation between the retrocorneal membrane and the posterior cornea. So just one of our examples from my practice. So this is a 55-year-old gentleman. He was a non-diabetic. And when he presented to us, he had taken over-the-counter steroid-containing eye drops for eye flu. So he had this infiltrate, an overlying epithelial defect, and a hypopyon, as we can see. A closer look also revealed keratic precipitates at the top of the lesion, which brought to mind the possibility, a strong possibility of it being a herpetic stromal keratouveitis. And this was the epithelial defect. But because he had taken steroid-containing eye drops, a possibility of a fungal or other etiology was, we always had to entertain that. And so like standard protocol, scrapings and culture were negative for any organism. The IVCM was negative for hyphae, it was repeated twice. And the AC tap, which was done subsequently, was also negative for the viral etiology. And this is just because, once we are treating patients clinically, sometimes we want to be a little overcautious and we will be giving mixed treatment because we don't know what the etiology is. And so this patient was, because of the possibility of viral, he was kept on a therapeutic dose of antiviral, but also initially I had continued him on fortified antibiotics, but we can see there was no improvement in that. And so this is the ASOCT, which was actually done on the day the patient had first presented to us, and we can see this retrocorneal plaque with smooth demarcation between the endothelium and the plaque. And so this is fairly clear, smooth borders. And also keeping in mind the KPs and not responding to fortified antibiotics, the patient was started on oral steroids. Topical were avoided because of the epithelial defect, in addition to the oral antiviral. And we can see that within 3 days, the hypopyon had disappeared, the retrocorneal plaque had decreased, and over the course of the next week, the patient healed completely. This is another case, known diabetic, presented 5 days after cataract surgery with endophthalmitis and a phacotunnel infection. The ASOCT shows that the lesion was localized to the corneal tunnel at the inner lip of the phacotunnel. The patient underwent a vitrectomy, and prophylactically again, considering it to be a possible fungal etiology, intracameral and intrastromal voriconazole was given. 3 weeks after the vitrectomy and these multiple injections, the ASOCT, the clinical picture and the ASOCT suggested that the lesion was not responding, and perhaps it was extending deeper and abutting the endothelium. So decision to perform a PAC-CXL was taken. This is the original lesion. And so 6 weeks later, post PAC-CXL, there was healing with scarring. And so in this case, to quite an extent, the ASOCT was helpful in monitoring both progression and resolution. And this is a case of follicular keratoconjunctivitis, clinically with coarse punctate epitheliopathy. Classic for microsporidia. The ASOCT also shows us the classic lesions which are limited to the epithelium and not going into the stroma. So there are various etiologies. So that's how ASOCT is helpful vis-a-vis adenoviral conjunctivitis, where we have subepithelial scars. Sometimes in the intervening phase there can be a confusion whether it's an epithelial or a subepithelial lesion, and that's what ASOCT helps us. Coming to the second part, in vivo confocal microscopy is the third eye. And the laser scanning HRT IVCM enables a higher resolution. It allows us almost an 800 times cellular magnification with a very low axial resolution of 1 to 2 microns. So the IVCM can image fungal hyphae, pythium, yeast, Acanthamoeba cis, microsporidia, and nocardia, which is a filamentous bacillus. Most bacteria, apart from nocardia, however, cannot be visualized, though their footprints in the terms of scars and inflammatory cells may be seen. So this is how classical fungal hyphae look like: highly reflective, branching, interlocking structures, and usually 3 to 10 microns in diameter, not seen in isolation usually. These can be sometimes, if they are isolated or few, can be confused with nerves, which are usually thicker and branch more regularly. Fungal filaments with spore-like structures have also been shown in this study from the Arvind group, where they were seen in 3% of the cases, and they mentioned that sporulation on in vivo confocal microscopy might suggest a poorer prognosis because it's a fungus which has exhausted its nutrient supply. So this was another example, a 35-year-old lady referred as having a ring infiltrate on treatment with antifungals from outside. And so confocal is my go-to technology always. Till we center scraping, but till then, because we know this is a classic wreath-like pattern which was seen, not a classic ring-like infiltrate, but a wreath pattern. And this was the confocal microscopy, showing hyphae-like structures again. I'll come back to this slide. So the Gram stain and modified ZN stain showed nocardia. And we can see that the confocal microscopy, before we got these results, we'd already done that. It was showing these beaded filaments, very classic beaded filaments, and this was nocardia clinically as well as on imaging. But not always is it possible to differentiate the nocardia filaments from fungal hyphae or from pythium for that matter. So this patient on then topical amikacin improved over the course of 6 weeks. This was a 25-year-old male with keratitis and keratoneuritis, and we can see the classic acanthamoeba cysts as shown by the yellow arrow. These cysts are usually 10 to 20 microns in diameter, but they may vary in size and be very large. From the same patient, again, cysts varying in size. Trophozoites can also be seen. Unfortunately, I don't have them in this example. But cysts can also be confused with other brightly reflecting cells, and that's important to recognize. So they can be confused with the nuclei of epithelial cells and inflammatory cells, which will be much larger in number, whereas cysts will be relatively lesser in number, and they will either be in clusters or in chains and not irregularly distributed. Microsporidial keratoconjunctivitis is another disease where we can, on confocal microscopy, this is an oblique view where it nicely shows you the multiple ovoid pinpoint spore-like structures. So this was what we published in BGO. You can see these spore-like structures as well as rosette formation, because that's a cluster of probably the apoptotic infected cells which will get shed off. And so there's a difference. The spores are much smaller than the acanthamoeba cyst. So the important thing is that acanthamoeba and fungal keratitis, IVCM has a broad role, because where we cannot get the cultures or the lesions are deeper, we get a direct imaging at the first go itself. Cultures may take 2 weeks, even positive cases, cultures may take up to 2 weeks. And like I mentioned, those lesions located in the deep stroma cannot be accessed unless one goes in for a biopsy or other invasive procedures. So this was just an interesting paper which was published just now in 2023, where they compared the group which had just diagnosis of acanthamoeba keratitis based on culture vis-a-vis culture and IVCM. I'll just take a minute more. And so it was seen that the patients who had the diagnosis made on the confocal microscopy had much better outcomes in terms of earlier diagnosis as well as visual acuity. And similarly for IVCM in fungal keratitis, there's a high sensitivity, and up to 90% of the fungal keratitis can be diagnosed on confocal, sometimes even more than the culture. So the last confocal has a high sensitivity and specificity for both fungal and acanthamoeba keratitis, and we should be using it. If one has access to it, it should be used as far as possible. Thank you very much.
Thank you very much, Dr. Chintan. Does anybody have any questions on the first two talks? We had some beautiful case examples by Dr. Mona as well as Dr. Chintan on use of ASOCT as well as confocal microscopy. Yes, ma'am.
Good morning. Question for Dr. Mona Bhargava. It was interesting to see that hair filament going into the AC. I was just curious to know what you did with that hair filament, and how did you, the hair filament that you showed, which was tracking down into the AC. Yeah. What did you do to that? Did you remove it or did you have to leave it? Because there was no inflammation, the surrounding stroma was absolutely clear. So just was curious to know. Oh.
Please.
So the surrounding stroma was absolutely quiet.
It disappeared in the anterior chamber.
One small question for Dr. Chintan. The herpetic presentation that you showed, where you gave oral valcyclovir and you gave topical steroids. It was just lucky that it went away. But what steroid did you use and for how long did you use?
So I mentioned we did not use topical steroids till the epithelial defect had healed. We were giving antibiotics, topical antibiotics, and
oral steroid.
Oral, so that was Yes, we gave oral steroids, not topical steroids, once under cover of antivirals. And with that, the retrocorneal plaque, because it's basically inflammatory and hepatic keratouveitis, so which is why the plaque disappeared and the epithelial defect also gradually healed under cover of course, topical and systemic antivirals also, and also, of course, just a broad spectrum antibiotic cover.
Topical antiviral also?
Yes, so we added topical antiviral also. That is a controversial thing where sometimes, whether when systemic is there, whether one needs to add topical antivirals or not. I generally do tend to add, there is a publication in Cornea as well which has shown that topical and systemic has a benefit, but I think the other panel can also comment on
Yeah, no, that was a difficult case. I was actually discussing that with Dr. Patel up here. That you see hypopyon and you're thinking about virus and everything is negative. I'm sure everyone in the room will agree that at that point you basically throw in everything at the eye to make sure it gets better. I mean, I don't know what the next step would happen otherwise. You can probably, pass a suture. Yeah, it could have been fungal still, but I think everything was negative and you really have, there's this leap of faith that you have to take at that point.
Again for Dr. Mona, suppose that patient would not have been lost to follow-up. Otherwise, what was the plan? How would you remove that?
Actually, the plan would have been to remove it when it was going to the anterior chamber. Before it penetrated and entered into the anterior chamber, from the side port, the removal was.
Usually they are not visible under the microscope. Yeah. Okay, thank you.
One question for Dr. Chintan, madam. So your based decision on ASOCT and the confocal, you take it as a primary this thing along with the scraping when you find, or only non-healing?
For which, are you asking about a specific case or generally?
No, generally. In terms of infective cases, you take it only for non-healing cases, or?
No, so I think, at least in my view, doing a confocal for all cases would be a little bit of an overkill. If one gets things, because it's also a little time consuming, and it's the other thing about confocal is that it's very, very operator dependent. Your results depend on the skill of the operator as well, and so all studies recommend, and that there's one person who's dedicated to doing this. But anyway, in cases wherever one is not getting either results on scraping, so it's short of scraping, because cultures you sometimes may have to wait for a long time. And if you have access to it, then I think in whichever looks like a little atypical, definitely I would go ahead.
And ASOCT?
Yes, so now we've recently started using ASOCT more, because like I mentioned, it helps to tell you about the disease severity a little more. It helps you, and also in some cases, you see the things behind the infiltrate, the keratic precipitates, the other lesions better. So it gives you a more quantification of the disease severity, better than what you, complements the slit lamp, I would rather say. Good clinical skills, of course, can never be replaced.
And when you use ASOCT, do you always see the behind the infiltrate well? The images you showed looked like you could see the deep cornea quite well, but are there times that the infiltrate's so dense you cannot see well?
So again, I would say it's more for the infiltrates which are so dense. The dense infiltrates, that's where it would actually add value to our clinical whatever decision making we are doing. Where one can see through the cornea clearly, I think the clinical decision always takes point. But yes, the nature of the retrocorneal infiltrate, whether it's irregular, whether it's regular, I don't think what's mentioned in that paper is 100% true. You won't see it all the time. You see that very clear-cut demarcation line. But in fungal keratitis, we can try looking at those irregular borders, and maybe that guides us sometime.
Any more questions? Yes, ma'am.
question is for Dr. Chintan. Ma'am, you mentioned about using Paxi-XL in that tunnel infection case. I had a similar case, but it turned to, like, I had to do therapeutic keratoplasty. So can you elaborate on this, what extent we can go for Paxi-XL?
So again, I think for Paxi-XL, there are no clear-cut guidelines as such, but we've had very good results in these the tunnel infections, especially because the lesion is deep. You're not reaching it with any other thing and it's localized. So the Paxi-XL helps there. But yes, if the infiltrates are very large, you can end up even with a corneal melt or corneal perforations as well. So it's something which has to be done a little carefully, and the lesions, again, it's said that the very deep lesions perhaps don't respond as well because it may not be penetrating, but I think the mid to the deep lesions respond well, and you have to monitor them carefully.
Okay, thank you.
Next, we would have Dr. Bhaskar Srinivasan, who is a senior consultant in cornea and ocular surface in Shankar Nethralaya. So I'll be talking on corneal topography and tomography. Yes.
I'm sorry, the display seems to be a little bit dull. A very good morning to one and all. No financial disclosures to make here. Basically, we've come a long way from using keratometer to measure our corneal curvatures, to Placidus-based devices, to scanning set in terms of OpScan, and right now you primarily have Scheimpflug-based devices which are commonly used, and recently you have OCT-based devices which are being used for corneal curvature measurement as such. So where do we use a corneal topography or a tomography? Primarily pre and post refractive surgery patients, premium cataract surgery patients, and most commonly for diagnosis and management of corneal ectasias. Fuchs dystrophy, Dr. Patel will be covering, where subclinical edema is picked up very well with pentacam, and that's a separate topic by itself. So you do have the basic idea is you have illuminated rings which are put on the cornea, and the reflection is then looked at, and you get the curvature based on the reflected images, and this curvature gets converted to the power of your cornea. Generally, the hot colors are represented as red and the cool colors as blue. So when you're looking at the topographic maps, it's important to actually first have a look at the slit lamp, because if you just see a map and it shows some irregularity, it could be because of a scar, it could be because of any other reason. You cannot directly label it as keratoconus. So first thing would be to check the patient on the slit lamp. You would need to confirm the eye, the details that you're looking and seeing the same patient and the same eye. Check the topography of the other eye. Generally, you will have what is called as enantiomorphism, where you have a reasonably similar pattern. Again, if there is a difference in pattern between both the eyes and you're not seeing anything clinically in your slit lamp, that should give rise to some kind of a suspicion. And if you have access to previous maps of the same patient, always go and look at it to see if there's any change or worsening. So when you're looking at it, again, look at the demographic details, then look at the scale. So when you're looking at the scale, you need to look at the interval at which your color coding is there, because we normally tend to get so used to just seeing the color codes, we get a little bit carried off. So if this difference is 0.5 or this difference is 0.25 or if this difference is 1, sometimes subtle changes might be masked. So you need to look at the values that are there at the side. Again, you can call it as an absolute scale when you're starting off from, say, a 9 to 101 as far as the TMS is concerned, and a normalized scale where you are customizing these values to the patient's cornea. So the picture on the right seems to be, when you look at it without looking at the numbers, you feel that it's a very steep cornea, but actually it's a normal cornea. So always have a look at where your color codes are and what it represents in that particular printout that you have in your hand. When you're looking at the type of map, you have something called as a sagittal or the axial scan, which gives you a broad idea about the overall curvature of the cornea with respect to the center. It's nice to see it, but subtle changes, especially in the periphery, or subtle changes like in a post-refractive surgery patient, it might not be able to pick up. If you look at this map on the left, it's very difficult for you to swear and say that yes, this patient has had a refractive surgery. The moment you put the tangential map, the power transition between the peripheral untreated and the treated area becomes a lot more obvious. So this is again something that you would want to use selectively in certain patients. Again, you need to look at the patterns. You can start off with a round oval. You have asymmetric or a symmetric bow tie. What you are looking at is skewing. If you have a significant skewing, then that eye is more likely to be having an ectasia. And then you come to the statistical information that is available in terms of the SIMK, SAI and SRI. It's important to know if the value is higher, it indicates an irregular cornea. A PVA tends to kind of give you, for that particular cornea, what would probably be the visual acuity that the patient can have. And we are lucky that we don't have to remember most of this, because most of the machine comes with inherent indices which tells us that yes, there is a possibility or a likelihood of it being keratoconic. So these are just representative samples of certain patients with mild or moderate keratoconus pre and post suture removal, where you can see an improvement in the astigmatism and the superior steepening which is seen in a TMD, and a post myopic ablation, one which is reasonably centered and one which is significantly decentered. Again, if you had put a tangential map, this difference of centration would have been a lot more obvious in this image. But Placido's disc comes with its limitations. It has a limited coverage area. You don't get the information about the posterior surface, you don't get information about the thickness, and you have the component of a displaced apex, whereby if the center of fixation and the vertex are not same, it might appear to be keratoconic, whereas it is not. So therein comes the role of Scheimpflug based devices. The most commonly used probably is the pentacam, and it gives you the corneal tomography, it gives you the pachymetry, it gives you the anterior chamber details, and further information also is available. It's based on the Scheimpflug principle, where your objective picture plane and the film plane focus at the same area to give you a better depth of focus, as seen on the picture. I'm sorry, it's a little bit dull. And the basic idea about the Scheimpflug based devices, it gives you elevation. So you say use a reference curvature, and points which are above or points which are below that curvature are highlighted, and that kind of tells you. So you do it for the anterior curvature, anterior surface of the cornea, you do it for the posterior surface of the cornea. You could use either a best fit sphere, you could use a best fit toric, or you could use a best fit toric ellipsoid. When you're primarily looking at patients for ruling out keratoconus as a pre-refractive screening tool, it's easier to put a best fit sphere. So anything which is abnormal tends to kind of get picked up. When you are analyzing a particular case in more details, you might want to go to a best fit toric or a toric ellipsoid. Again, you have different screening tools in terms of a fast screening, a 4-quad map, bad display, Zerny case analysis. I'll probably be sticking to the 4-quad and the bad display here. So it basically gives you 4 maps which tells you the anterior curvature, which is sagittal or the axial. It gives you your pachymetric curvature, and it tells you the anterior and the posterior elevation values. And in the left side, you can actually see the demographic data, the front surface details, the back surface details, the thickness details, and the anterior chamber details. So when you're looking at a map like this, yes, you see an irregular asymmetric bow tie pattern of astigmatism. You see an increased anterior surface elevation, increased posterior surface elevation. The K-max is high. Obviously, this is keratoconus. And a picture like this looks, sometimes when you just have the Placido's based device, you might just directly label it as a pellucid marginal degeneration, but it's important to have a 4-quad map which actually convincingly tells you that this is not a pellucid degeneration, it's more like a sagging keratoconus that you're seeing. Unlike this image where you see again a similar picture, but you see a thinning which is going beyond, you have a pachymetric map which shows a bell-shaped curvature. For a PMD, because the periphery, the pathology is in the periphery, you might want to change the scan diameter to a 12 mm map to look at the periphery. And even though there are assumed points in the periphery, you can actually see the bell-shaped pattern of the pachymetric map. And here when you look at it, the thickness is kind of being picked up as 423. Because these points are not coming into account, because these are extrapolated. So always if you're doing a CXL for a pellucid marginal degeneration, look at the Scheimpflug or the OCT images to look at the thinnest point. Be sure that you have reasonable corneal thickness to plan the procedure as such. The enhanced Bellin-Ambrosio scale uses excludes the 4 mm thinnest point curvature, and then puts the best fit sphere. So the differences between the anterior and the posterior surface are a little bit more pronounced, and it gives you along with that a pachymetric progression indices to help us identify abnormal corneas and be careful. So this is basically a normal map where you don't really see any of these patterns changing into yellow or red. And this map shows both the anterior and the posterior elevation are borderline, the pachymetric thickness is less, the progression is borderline, which picks it up as a keratoconic cornea. Bellin has also given an ABCD display where basically is looking at the anterior curvature, the posterior curvature, and the thinnest pachy and the vision. And the green and the red basically are the 80% and the 80% and the 95% confidence intervals for a normal cornea and for a keratoconic cornea. You can use this to kind of document a progression or stability of a patient of keratoconus. So points to remember would be, in a sagittal map, look for an asymmetric bow tie, look for skewing, look for superior inferior difference, and any of this kind of a pattern if you see, you would probably be a little bit suspicious. When you're looking at elevation maps, you're basically looking at a posterior elevation of around 17, an anterior elevation of around 12, difference between both an anterior and the posterior of around 5. But these are not sacrosanct. You can't have one particular index and you say this one particular point is absolutely suggestive of keratoconus. Unfortunately, we don't have that at this point of time. Again, a pachymetric map also is helpful. Any pachymetry which is less than 470, you would want to be a little bit careful if you are considering refractive procedure as such. Pentacam along with Corvus can give you something called as a TBI and CBI, and Rashmi would be covering it, and this tries to help us improve the predictability of an eye being keratoconic and avoiding a refractive procedure. You also have something called as a holiday report, which basically gives you, in addition, the asphericity of the cornea. It also gives us the higher order aberration and the chord mu, which will help us probably in deciding whether we would want to opt for a multifocal or a premium IOL in that particular patient. Galilei and Cirrus also are similar Scheimpflug based devices, but they have in addition a Placidos based disc. The indices are slightly different, but the basic principle of reading the map is the same, except for the fact that the BFS is converted to a best fit toric as far as the Cirrus is concerned. Eye tracing can use ocular aberration and a ray tracing phenomena along with a topographic overlay. It tells you whether the problem lies in the cornea or the problem lies internally, and that helps you manage the patient. And it can also be used in your toric IOL, especially if there is a misalignment of the lenses, to know how much you need to align your IOL to reduce the amount of astigmatism. Coming to ASOCT, we now have a couple of OCTs which also allow us to have a topographic details, the Cassia, the Anterion, and MS39 to name a few. And basically, similar to the Pentacam, it can give you your 4-quad map, it can give you your anterior curvature, it can give you your thickness profiles, it can give you your asphericity details. It can also give you epithelial thickness. In MS39, it can also give you your epithelial and your stromal thickness separation as such. And it also has the indices which are similar to what are there in Cirrus, which tells you whether the possibility of keratoconus is there or not. It tells you the grading of keratoconus on an ABCD scale. It gives you the type of cone. And again, it's simple because these are all patterns which are seen as red and green, so you know where the values fit just by looking at the graph. It also gives you keratoconus progression maps to know how the anterior curvature, the posterior curvature is worsening when you follow up these patients. The epithelial donut pattern is very well appreciated here, where there is a thickness, the epithelium is thinnest over the cone. But sometimes it might be reversed. Here you actually look at a Pachy value of around 347. You might think, okay, you want to do a CXL for this patient. But look at the epithelial look at the maximum thickness is 67 and the stromal thickness is 280. In fact, here the epithelium was thickest over the area of the cone. And if you look at the OCT, you can actually see there is a depression. This entire crater has been filled by the epithelium. And if you had gone ahead and done a CXL, you would have actually ended up having endothelial toxicity in this patient. So when you're dealing with a thinner cornea and you want to do a cross linkage, it makes sense to actually do an epithelial mapping. Pre and post refractive surgery, again, whether it is LASIK, whether it is SMILE, whether it is ICL, OCT will enable you to assess these patients preoperatively and follow them up postoperatively. To conclude, we have significant improvement in our imaging devices, but subclinical or formifrust keratoconus still remains a challenge. There is no single criteria which can say, yes, this is suggestive of, definitely suggestive of keratoconus with 100% specificity and sensitivity. You need to evaluate these patients in a detailed manner, both the anterior, the posterior curvature, the elevation, thickness, epithelial mapping, biomechanics, and you need to put the jigsaw together to finally conclude whether this patient is an ideal patient for a refractive procedure. Thank you.
Thank you. Thank you so much, sir. We'll have our questions after the next speaker, sir. I invite Dr. Reshmi Deshmukh. So she's a cornea consultant in LVPI Hyderabad. She'll be giving us a talk on the corneal biomechanics, basic to advanced. Over to you.
Thank you, Dr. Nishant. Yeah. So in the next 12 minutes, I'll be talking on corneal biomechanics, starting from the basics and then going through how the output displays are projected, mainly in the Corvus ST. So why is corneal biomechanics important? In order to maintain a corneal shape, because that is the main determinant of ocular refraction. So we want the cornea to be soft enough so that it bulges out into a hemisphere, but also it should be stiff in order to maintain its shape and to resist the intraocular pressure. And at the same time, while doing all these functions, it needs to remain transparent, which depends on the interplay of the extracellular matrix and the various components. So what are the properties of biomaterials on which biomechanics is measured? First is the elasticity, which is the capability of a body to change the shape when a force is applied, and then once the force is removed, it should come back to its normal shape. That is elasticity. Second is stiffness, which is the resistance to this deformation that the object is going to have when you apply that force. Strain is actually the measurement of the deformation which is happening, so the change in the length as compared to the original length, which is called as the strain, and the ratio of the force which is required to achieve this strain is called as the stress. So these are the basic things which determine how the corneal viscoelastic properties are determined. Viscosity again is the measure of the resistance against the progressive deformation and by the shear stress and the tensile stress. So cornea is a viscoelastic substance. It has its elastic properties mainly by the collagen fibers, and the viscous properties are driven by the extracellular matrix components. Now, corneal biomechanics is influenced by various factors such as corneal thickness, intraocular pressure of the patient, age and smoking cause increased corneal biomechanical stiffening, same with diabetes mellitus. And again, there are effects of various surgeries which might cause biomechanical weakening, and this is what we need to measure. So it is relevant in cases of corneal ectasia such as post-refractive or keratoconus. People also use it in orthokeratology and glaucoma management, and to see the stiffening effect after collagen cross-linking is where its relevance is seen. So how is corneal biomechanics measured? Mainly it is the Corvis ST that I'm going to talk about, but there are other methods as well, such as the ocular response analyzer, Brillouin microscopy, elastography, and experimentally it is seen by enzymatic digestion methods. So coming to Corvis ST, it is a Scheimpflug camera, which is an ultra high speed camera and measures the Scheimpflug images over 8.5 millimeter horizontal diameter of the cornea. And what it does is it sends out a collimated air pulse in the central part of the cornea in the central 0.5 millimeters, and with a maximum pump pressure which is fixed as 25 kilopascal. And the light rays which it uses is the UV LED light of the wavelength of 455 nanometers to measure the Scheimpflug images. So these are the various phases that it measures. First is before any collimated air pulse is shown, that is the A, before measurement. Sorry, I don't have the cursor here. Then once the cornea starts to go down, it measures the first applanation length. Then once the cornea goes in, there is a point at highest concavity where the cornea kind of stays for a bit and then tries to recoil back when the second applanation, like the D phase, is measured. And last is E, where it is after measurements coming back to its pre-measurement values. So once when the central corneal thickness measurement is taken is before the applanation phase. So that is in the A phase when the collimated air pulse is not yet thrown. And during the first applanation is when the intraocular pressure is essentially measured by the Corvis. And then Scheimpflug imaging is given for all these different phases in a horizontal cross section. So we see different kinds of parameters on a Corvis map, such as A1 length, A2 length, and things like that. So what are those? So at the time of first applanation, in the central 0.5 millimeters area when it gets applanated, the length of the tissue that gets applanated is measured. The velocity with which it got applanated as compared to its original shape is given as A1 velocity. And the time it took for this applanation to happen is called as A1 time. This is also measured in the second applanation phase. Then, like I mentioned, it goes to a highest concavity area where it kind of oscillates for a little while. So if you look at the graph on the side, then you see that the highest concavity area is measured against the time for which it oscillated in that area, and that is what is called as the inverse concave radius, or the integrated radius, sorry. And again, the same measurements are taken at the time of second applanation when the cornea is kind of recoiling back. Now there are again terms called as deflection amplitude, whole eye movement, and deformation amplitude. And what are those? So when there is a collimated air pulse thrown at the globe, the entire globe is also going to move along with the deformation of the cornea. So the entire movement of the corneal apex from its original position is called as the deformation amplitude. But when we subtract the whole eye movement also from there, then we get the deflection amplitude of the cornea alone. The whole eye movement is also going to depend on your scleral mineral rigidity as well as the presence of orbital fat around the eyeball. These factors are not taken into account when you measure the deflection amplitude. So coming to the DA ratio, which is what usually we look at when we talk about corneal biomechanical stiffness. So it is the ratio of the deformation amplitude at the apex in the center versus the 2 millimeter nasal and temporal points from the apex like we see. So of course if the cornea is softer, then the DA ratio will be higher because the apex is going to get deformed a little more as compared to the mid-peripheral points. And same way, if the cornea is a little stiffer, then your DA ratio is going to be a little small. So these all these parameters are displayed in something called as a DCR report or the dynamic corneal response report, where we see that all the parameters are given along with the Scheimpflug images for each phase. And something else is also added in Corvis ST, which is the biomechanically compensated IOP. So in biomechanical compensated IOP, the Corvis also takes into account the effect of corneal thickness and other corneal properties, viscoelastic properties, to give us a biomechanically corrected IOP. And it also takes into account things like asphericity and the changes with age and systemic conditions. So this biomechanically corrected IOP is used as the Vinci-Guerra screening report. This is the second output display which you get in Corvis. So if you see the red dots on each graph, the light gray line shows the first standard deviation and the dark gray line shows the second standard deviation, and the red dot is actually your patient measurement. So you can make out whether this is within the normal range or it is outside 2 standard deviations for your particular patient. Another thing that is added in the Vinci-Guerra screening report is the stiffness parameter as well as the CBI at the bottom there, which is the Corvis biomechanical index. So stiffness parameter is, there can be an SPA1 or an SPHC, but the main thing that we look at is SPA1, which is stiffness parameter at the time of applanation 1. So stiffness, what is stiffness is? It is the pressure during the moment divided by the value of how much the cornea got displaced. So in SPA1, the displacement will correspond to the distance between the corneal apex at the beginning of the examination versus at the time of the first applanation. And then what is Corvis biomechanical index? It is a AI based index which is based on logistic regression formula, including the different parameters that were seen in the DCR reports. And what it does, it differentiates subclinical keratoconus versus a healthy cornea when your corneal topography is essentially normal, and studies have shown its sensitivity to be around 100% and around a 98% specificity. So this is mainly used when the cornea is biomechanically weak but it is not yet showing up on the corneal topography, versus a TBI, which is a tomographic biomechanical index, in which it is going to show if a normal cornea, which is healthy right now, is susceptible to developing weakness and ectasia in the future. But it is not saying whether the cornea is weak right now or not. And this combines tomographic and biomechanical properties, and again it is also an AI based index. Both the CBI and the TBI are shown on the biomechanical tomographic assessment map, which is the most commonly used map when you are screening for refractive surgeries. And when you look at the black line on all the maps there, so the black line represents your patient data, the green curve is your normal population, and the red curve is your keratogonic population. Based on your patient's values, it is going to show where the values for your patients lie, whether it is more towards corneal ectasia or more towards your normal populations. Then coming to the stress strain curve, this is the newer map which has come now. So in the stress strain curve, it is going to measure the elastic property of the cornea. If you look at the graph again, that the more, if the cornea is more soft, then less amount of stress is going to cause more amount of strain. So a softer cornea is going to have a curve which is slightly more towards the right side as compared to a cornea which is stiff, which will have the curve more towards the left side. If your SSI is 1, it is a healthy tissue. Like I mentioned, softer behavior will have SSI less than 1 because less stress will be required, and a stiffer cornea will have a more SSI of more than 1. And this is the biomechanical comparison display, which actually compares your corneal weakness over, or biomechanics over 2 visits. So for example, visit A was the previous visit and visit B is the current visit. So in the comparison maps, it is going to show how the stiffness parameter changed over time and how was the SSI over time. And for ease, if you just look at the display, it also shows whether the cornea has become softer. Like in this case, it is showing that the corneal biomechanics has become weaker over time. So now coming to clinical scenarios where it can be used, of course after refractive surgery, multiple studies have shown that corneal biomechanics does become weaker and different parameters change. Then when we want to differentiate early keratoconus from normal, the TBI as well as the CBI both have been shown to have great specificity and sensitivity, and a cutoff point for TBI of less than 0.5 is what is considered to differentiate from the normal. And just now, like I showed the comparison display, in post-collagen cross-linking patients, the stiffness can be seen whether the cornea is becoming weaker or getting stiffer or is remaining the same. And just a couple of practical examples. For example, this was the map which I showed earlier as well, where the patient's parameters are within the normal range, the CBI is in the green range, the TBI is also fairly in the middle. So this would be a case where we would say that this is normal. We also need to see that when we are looking at the CBI, like you see there are two options there, one is untreated and one is post-LVC. So we need to choose the appropriate option of the patient that we are seeing. If it is untreated, then the red curve is mainly of the keratoconic population, but when we take post-LVC as the selection, then the red curve is of the post-LASIK ectasia cases. Versus in keratoconus, like we see the TBI and the CBI are all more towards the red zone, and if you look at the patient data with that black line, it all goes in the red curves. It can sometimes be used in doubtful cases. For example, this was a thick cornea with a relatively small diameter and showing up on the bad display as a suspicious cornea. But if you look at the corneal biomechanics, it shows that the corneal biomechanics is not really weak. In these kind of cases, you might be able to use your Corvus to differentiate whether a cornea is ectatic or not. So just to summarize, Corvus ST is a non-contact tonometer but combined with a Scheimpflug imaging technology to assess corneal biomechanics. It helps in differentiating normal topography but from keratoconic cornea such as the CBI versus the TBI, where normal normal cornea which is susceptible to developing a keratoconus can also be seen. And again, it helps in assessing corneal biomechanics after collagen cross-linking, but it needs to be further explored where all we can use it in practical clinical scenarios. Thank you.
Thank you, Rashmi, and thank you, Dr. Bhaskar. I think those topography and biomechanics are not topics which can be covered easily in 10 to 12 minutes. A question for the panelists. How often do you use biomechanics as a part of your refractive workup? Is it for every patient? Is it for patients who are suspicious?
At SN, we are using it for every patient. I mean, once you have the access to the machine, it might make sense to use it for every patient.
We don't routinely use it, though for full disclosure, I've cut back my refractive surgery practice as well.
So we do have access to Corvus, although, as Dr. Patel would know, most of the software is not approved for use by the US FDA. We have the research version. We did some of the initial work from Hong Kong where it was approved for use. We use it for refractive cases when there is any doubt, but we use it to collect data for pretty much every case with corneal ectasia. So, just to add on to what is already known. And there is a new version now because there was a lot of talk about differentiation in corneal biomechanics in Caucasian and Asian eyes. So earlier this year, they released a Chinese version of CBI. It's called CCBI. I'm sure there is somebody here in the booth outside in the industry area to sort of tell us more. I don't think we're going to get with CBI to a place where we're going to use it for every single case. But, if someone has a big practice and we also have to remember you end up screening out more cases. So some people, especially non-academic centers are well aware of that.
Yes, because as a refractive surgeon, one always, if one doesn't have access to biomechanics, one feels guilty whether one is doing the right thing or not. So that's the thing. Yes, we have a question from
you. Are we making any decisions to in refractive surgery on the basis of biomechanics? If it is a softer cornea, are we rejecting, or alone on the basis of corneal biomechanics or in combination with other modalities?
So one of the important things here is that when we are looking at the corneal biomechanical data and the prediction that it is showing the prediction based on LASIK. So in certain doubtful cases, if the topography itself is also a little borderline and you see that the corneal biomechanics is weak, but the refractive error is low, you might want to towards surface ablation rather than going towards LASIK is how we are practically currently using it, because it predicts for LASIK, but it does not really tell you about surface ablation at the moment. So if you have a doubt looking at the corneal biomechanics that the cornea is relatively weaker and there is certain amount of ablation that you are planning, you could err towards doing a PRK for such cases.
Like most of us may not be having access to this modality. Dr. Bhaskar rightly pointed out, if you have cornea thin, which is 470 microns, you look for the corneal thickness. If the corneal epithelial thickness is low, should we go for corneal biomechanics
I
and
wouldn't say
decide?
it is a mandatory thing at the moment in the preoperative refractive screening. It's like without topography we can't make do. I don't think corneal biomechanics is like that at the moment at least.
I mean, at this point of time, it's not a mandatory test. But obviously, if you have doubts, then you have to take a call whether you want to be safe by getting the test done in a center close by which has the machine, or talking to your patient that, okay, we would reassess you 6 months down the line and then take a call, look at couple of repeat imaging to see if there's any change. And then, as Rashmi put it, if at all there is, the error is small, you might want to err towards a PRK. If the error is larger, you might want to err towards an ICL as an option for the patient. One thing which I forgot to add is, if you're doing a pentacam, it's mandatory that you do it with in an absolutely normal eye. So no paracane, no applanation, no dilatation in that eye, because the values tend to get altered by any of these medications. So that would basically mean that if you're seeing a patient in the OPD today and you want to investigate him for a fitness for refractive procedure, you might actually have to call him back a subsequent day for the test, or your center, you have to prime the patient that yes, if you're keen for refractive surgery, we would be getting these tests done, and then the consultation will happen.
Just a short comment. I've been using the Corvus for the past 8 years now. So I've been routinely using for all cases. I just want to add is that CBI, TBI, one more parameters, the SPA1, which should be accounted in all cases. So whether it's stiff or not, it's a single parameter which helps to differentiate these borderline cases very well. So I feel refractive screening is a multimodal imaging concept where epithelial mapping, Corvus and Pentagam, all three together would help much better to differentiate these borderline cases.
That's definitely true. I think all these investigations do add an added layer of safety, but also an added layer of complexity. So I think depending on the workflow and how in abnormal cases one must certainly, in the otherwise regular topography, I think it can be a personal call. Yeah.
One question, Dr. Rashmi. Post cross-linking, how do these TBI, CBI values change and how much do they change?
So TBI and CBI values don't change much post cross-linking because the
SSI
cornea
change?
is already ectatic.
Yeah,
so the
what
CBI is
changes?
always going to be within the red parameter because it is an ectatic and a biomechanically weak cornea. After cross-linking, what you are looking at is the stress strain index, whether it is getting maintained or it is going towards the stiffer side. You don't want the cornea to go weaker and weaker.
So does the SSI change after
The
cross-linking?
SSI changes. So that is
How
why
much
the
does it
comparison
change by?
display that it shows. So over time, you can see whether the corneal biomechanical weakening is increasing or remaining the same, or it is going towards the stiffer side. But the CBI and TBI won't change
Okay,
essentially.
the SSI changes by how much? You said it is less than
So
1?
that would
more
depend
than
from
1?
case to case because it's an index.
On an average, how much change would you expect?
No, so it is an index. It is not an absolute value.
Okay.
Same as CBI and TBI, it is an index actually.
The other thing which I want to add post cross-linking is that the Schimflung imaging which occurs in the Corvus post, this is a lot of scattering. So they have published that after 1 year, you can be more sure about the SSI values. So even for follow-up, how the cornea stiffening and all. So in most cases, you may not get sometimes you don't get the actual stiffening shown on the SSI, but still the patient over a period of years, we have not seen any progression. So I would say post cross-linking, you have to be cautious. You can't rely because the imaging modality of Schimflung, post cross-linking, it will not be that accurate.
Yeah, so I don't know if you have access to that software which has a video that plays pre and post cross-linking.
No, not really.
So it's not objective again, but so there's this overlap video, small clip that comes in Corvus. We have access to that. There are different versions now of research software, but you see the puff of air indenting the cornea pre-cross-linking and post-cross-linking. So there is a difference, but it's not objective again. And to add on to what Dr. Sharma asked earlier, you don't have access to OCE, optical coherence elastography, which is supposed to be more accurate compared to biomechanics alone. And then there are people, Scarcelli's work, who have done brilliant microscopy, which shows focal changes in keratoconus rather than global changes. I think they are available commercially now. The system is called BOSS, but they don't have the FDA approval yet. So there are other things in the pipeline.
Thank you. So we'll move on to our next speaker. We have Dr. Vishal Janji. So he's the professor of University of Pittsburgh in cornea, and he'll be talking to us on the advances in dry eye imaging. Over to you, sir.
Can I get the slides on? Okay, good. So imaging can be as fancy as you want it to be, isn't it? So I'll be talking on a dry topic, literally. Imaging for dry eye disease. I don't have any relevant financial disclosures. Let's talk a little bit about principles of dry eye disease and imaging and testing. So we're looking to measure the tear film secretion, the stability of the tear film, the integrity of the tear film, and you can also do some lab tests depending on where you work and how big your tear film dry eye practice is. If you want to quantify the tear film, you basically commonly use tear film strips. The most commonly used test is Schirmer's test. There are advantages of using Schirmer's test, especially in a research setting. Of those of you who are doing dry eye research, they know that you can basically collect the tears and use the same Schirmer's for a bunch of things. The old school testing can include phenol red test, the Jones basic dye test, the cotton thread test, and also the fluorescent clearance test, which are not very commonly performed in the clinics. In fact, if you speak to most of the academic centers, people are moving away from Schirmer's test as well, because the most commonly used test is actually for tear film stability, the tear film breakup time. Any clinical trial, any new drug, anything that comes in the market, one of the main outcome measures is the tear film breakup test, especially the ones for treating dry eye disease. Where imaging plays some role is when you don't want to do sort of an invasive tear film breakup time. It's really not invasive, it's the timing of the test as well. Most of us, if you have access to residents and fellows, you will see that they will forget to do the tear film breakup test as one of the first tests when the patient sits on a slit lamp. You can actually measure that in a non-invasive fashion using certain platforms. We'll be discussing some of these later on. You can measure the tear film integrity basically simply by looking at the staining patterns of cornea and conjunctiva using fluorescent dye, which is the most commonly used dye in clinical practice. You can use rose bengal and lissamine green as well. If you're in a practice which has a lot of patients with severe dry eye, Sjogren syndrome, graft versus host disease, you should have access to rose bengal and lissamine green as well. One of the most commonly and easily available and free software is basically the NEI grading. We have incorporated this in the electronic health record as well. It's not difficult to incorporate that. If you have a large dry eye practice, so-called dry eye suites where we, offer fancy treatments, useful though, to the patients, it's good to have, these grading systems. And they're actually good for the patients to look at as well before and after treatment. So for every single patient, we do a baseline dry eye questionnaire. The DEQ5 is very easy. You can do the OSDI as well, which is a little bit more complex. There are other grading systems available as well. SPEED is another commonly used system. So any positive symptom score will lead to a more detailed examination, which includes breakup time, invasive or non-invasive, ocular surface staining. And if you have access to tear film osmolarity systems, you can use one of them as well. This is an actual picture of a patient from a software called, a machine called Keratograph, which is available from Oculus, if I'm not mistaken. So basically, the machine gives you an automated tear film breakup time, and it's non-invasive. Basically, the patient just sits in front of the machine, and you can look at the Myers. There are machines that will actually measure the tear film meniscus for you as well. This is more relevant in patients where we're sort of intervening, especially putting a punctal plug. You will see that in some patients, as soon as you put a punctal plug and you're not using any local topical anesthesia, you will see a tear film meniscus building up if you repeat the test in about half an hour or so. You can use anterior segment OCT for dry eye diagnosis, although again, that'll be a little bit of an overkill. A previous speaker has already mentioned about the principles of OCT. The average value of tear film thickness in healthy subjects is approximately 5 microns. You can, of course, use this same OCT to measure the thickness of the cornea and epithelial thickness mapping as well, which might be useful in patients with severe ocular surface disease, especially Sjogren's syndrome. And OCT can be also used to image the meibomian glands, which I feel is a more useful utilization of this expensive device. This is a picture that shows how you can look at the lower tear film meniscus height, and the radii can be measured as well. The meniscus height usually is about 1.64, and the radius is close to 1.8 millimeters. We do have access to one of the research devices, which is only a research device outside of Japan, otherwise it is not. It's basically a video keratographer which images the tear film over a period of 10 seconds. The patient is not supposed to blink for 10 seconds, and then it quantitatively analyzes the dynamic changes in the tear film. It gives you 2 objective parameters, which is, it's always good to have something objective for you to understand and also for the patient to understand. One of them is called SRI, Surface Regularity Index, and Surface Asymmetry Index. This is a TSAS map from a normal subject. You can see it's very regular, and the adjacent map belongs to a patient with dry eyes. The graph, the tiny graph on the side, it basically shows how the surface irregularity index, it sort of changes in a patient who has dry eyes. There is a modification of this machine which is commonly used in Japan, which also shows the patient sort of a vision chart and measures how blurry that vision chart gets with with eyes being kept open constantly over a period of 10 seconds. So that basically gives you a functional visual acuity as well. You can apply the same principle to an abrometer, which is again non-assessive assessment of visual disturbances. There are actual changes in HOAs, which are very pronounced in patients with dry eye. Again, not something that you need to do, but it's useful to quantify dry eye disease in patients who are suffering even from mild to moderate dry eyes. One of the things which is relatively new is interferometry, which allows us to analyze the lipid layer. It basically colored fringes that arise from the interference between the light reflected from the lipid layer. They are measured. Various studies have shown that there's a correlation between the dry eye symptoms and lipid layers that are thinner than 60 microns. And if the patient has low lipid layer, there's a higher probability of that patient having MGD. Not again that you cannot see MGD on clinical examination. One of the commonly used devices is LipiView. There are other devices. One of them is also called DR4 device, which is from Kowa, a Japanese company. The machine actually is able to capture a video in addition to giving the lipid layer thickness, which is the only useful parameter really from this machine. You can actually look at the rate of partial blink, which can be associated with dry eye symptoms in a patient. Meibomian gland assessment is also a very important parameter that needs to be evaluated in patients with dry eye disease. It's one of the most common causes of evaporative dry eye. You can objectively grade meibum, using a meibomian gland expressor from grade 0 to grade 3 in these patients. Which brings us to the topic of mebography, because if you see MGD, you have to measure that objectively, which involves in vivo imaging of meibomian glands. It's non-contact based on autofluorescence. You can actually look at the shape, integrity, and loss of meibomian glands, and the degree of meibomian gland dysfunction or altered architecture. It can guide towards diagnosis and treatment. These pictures are obtained again from keratograph from Oculus. As you can see, the normal structure in the top left corner, and with grade 1, grade 2, or mild, moderate, and severe MG loss, which can happen in patients with severe Sjogren's syndrome and also in ocular graft versus host disease. You can apply various AI parameters and try and isolate these images and try and grade them quantitatively. You don't have to rely on the company software. If you have access to a good software, you can write the program yourself. Something more fancy and I would say less useful is grading the bulbar redness. Some patients will come back to you telling you that they don't have any dry eyes, but they do have constant redness, and that doesn't look great on them. There are programs now inbuilt in machines that can actually grade the bulbar redness pre and post treatment and give you objective parameters that you can share with the patient. This is a machine which is not approved by the FDA. It's from Italy. As you can see, they have a huge database of normal patients, the normative database, and the machine actually gives you an assessment of non-invasive breakup time, the rate of partial blink over a period of 20 seconds or so, the thickness of lipid layer, height of the tear meniscus, and also the loss of meibomian glands, thereby giving you something objective to share with the patient. For those of you who work in a more academic practice and have access to confocal imaging and have a person to do a proper confocal imaging, you can look at epithelial thickness, the keratocyte density, nerve fiber density, reflectivity, and tortuosity in these patients. You can also look at patients who have corneal neuropathic pain, which is now commonly reported in up to 10 to 11% of cases after refractive surgery, especially after incisional refractive surgery. We don't use confocal as a routine test or a baseline diagnostic test in our setup. This is a slide which is from a paper in 2014 showing architecture of normal meibomian glands, and also the middle picture shows meibomian glands in a patient with Sjogren's. You can see the density of the glands has decreased. They sort of swell up a little bit. In the last picture, that panel shows a patient with Sjogren's syndrome. The acinar units of meibomian glands are small, and there is a lot of inflammation surrounding those glands as well. We don't do this anymore, but impression cytology, of course, old school method to look at severe dry eye. Again, very useful for research and to collect cells. You can see that the top panel, which is the normal conjunctival and corneal staining, showing a lot of PAS staining and almost a 1:1 NC ratio, the nucleocytoplasmic ratio, which decreases to about 1:6 to 1:7 in patients with mild dry eye, shown in the middle panel. If somebody has severe dry eye with Schirmer's close to 0, you will basically see a lot of pycnosis on the conjunctival as well as the corneal impression cytology. We do use, for research purposes, ocular eye washes and also this impression cytology device, which is slightly less invasive. It uses a polysulfone membrane instead of a nitrocellulose membrane. It increases the yield of cells from the conjunctival surface significantly, and you can use this impression cytology. Basically, the paper comes off for even flow cytometry, reverse PCR, and extraction of protein for further research. This is my last slide. I really want to highlight there's no ideal automated test available. We still absolutely rely on clinical examination, which is still the gold standard. What we've realized over the years is the currently available modalities, they do help in identification of defective tear film, especially the lipid layer. It can try and guide you towards targeted treatment, especially in meibomian gland dysfunction. You can monitor dry eye disease. It's patients always feel happy, so they are better educated, and the compliance is better. This, I found this online. The machine, it's a European company. They basically, the machine gives out a complete report, a treatment report, a follow-up report, blinking quality, a monocular report, and a binocular report to the patient. So this is what goes home with the patient. I'm sure if patient gets this pretty much once every 3 months, if they have severe dry eye, they would be more compliant towards the treatment that you are instituting. Thank you very much for your attention.
Thank you so much, sir. We'll have the questions at the end of the session. Now I'd like to invite Dr. Sanjay Patel, who is the professor of cornea and Mayo Eye Clinic in Minnesota. So he'll be talking to us on the corneal imaging and Fuchs endothelial corneal dystrophy. Over to you, Dr. Sanjay.
Okay, thank you. So from discussing the outside surface of the cornea, we're going to discuss the inside surface of the cornea. I do have disclosures. They are not related to this topic. So I think of imaging of the cornea for Fuchs dystrophy in two different ways. The first is structural imaging, and the second is functional imaging. And structural is some of the things we've already heard about, but specular microscopy, confocal microscopy, and retroillumination, which is really just slit lamp biomicroscopy. And functional, what I'm referring to there is actually looking at the function of the cornea with respect to its hydration status. So this would be Scheimpflug tomography or potentially OCT. And there's some key differences. With structural, you're really getting good high-resolution images. You can see cells, nerves, detailed structures of the cornea. But there's also a lot of variability in the measurements, and it takes a trained technician to do something like confocal microscopy, for example, but can make a very good quantitative research tool. But you also need to understand that morphology does not always equate with function. And so functional imaging tends to be measuring the surface contours or elevation. It is actually more repeatable, and aside from research, has a strong application in clinical practice. So if you're seeing patients with Fuchs dystrophy, either as a cataract surgeon or a cornea specialist, this is very important and very relevant clinically. And it really becomes an indirect assessment of function. So if we talk about structural very quickly, we're all familiar with confocal and specular imaging, and you can take images like this of corneas with Fuchs dystrophy, and sometimes you'll see cells well, sometimes you don't, sometimes they're quantifiable, sometimes they're not. But what you have to understand is those two images there belong to the same cornea. And when you have guttae present in Fuchs dystrophy, there's a lot of regional variation, and these imaging techniques are looking at very, very small areas of the endothelium, so you are subject to sampling errors. And this is what will happen if you try and measure. You can get almost any number that you want, and that's within one image of one cornea. So when you try and apply this to research where you're looking at changes over time, you've got such high variability that it doesn't really help you. And I would argue this does not help you in clinical practice. So if you take endothelial images and you're using them to make clinical decisions, I'm not sure exactly how you're doing that, okay? Now, confocal microscopy of Fuchs dystrophy, you can get some beautiful images, and it's not just changes in the endothelium, but you'll see changes in the anterior stroma. For example, the amount of light scatter or haze increases, but you also get depletion of keratocytes. We don't understand what that means, but it's real. And the same, you get changes in the subbasal nerves. They either disappear or you can't see them through fibrosis, and you get development of subepithelial fibrosis a lot sooner than you can see at the slit lamp. And so there are abnormal cells present even in mild Fuchs dystrophy, and potentially can affect vision. Retroillumination photography is a great way for photographing guttae, but it's actually difficult to do and to make it repeatable. And there's been various attempts at that, and as you can see in the images over here, anywhere you have a light reflex, you cannot see the guttae, and that introduces variability for repeated or prospective measurements. So functional imaging, I think, is very important, and it's just worth thinking about the basic form of corneal edema in Fuchs dystrophy. So in a normal cornea, you are not going to see edema at the slit lamp because it's not there. But in Fuchs dystrophy, when you begin to get edema, it's a focal, localized edema where it's the back surface of the cornea that starts to bulge towards the anterior chamber, and that can become more prominent, but at the slit lamp, you will not see it. Okay, it can be subclinical, okay, yet it's there. And eventually, as the barrier and the pump break down, you'll get more diffuse edema in Fuchs dystrophy. This becomes more clinically visible, clinically manifest. And these are Scheimpflug images that show that the two on the left have obvious edema, and it's the back surface of the cornea that displaces towards the anterior chamber. The two corneas on the right, even though they have very, very different corneal thicknesses, both have significant Fuchs dystrophy with subclinical edema. You can't see it here, okay? And you need the tomography maps to detect it. And so up above is what normal corneal thickness and posterior elevation map should look like. And down below is what you can see in Fuchs dystrophy with three critical features signifying subclinical edema. So here are some examples. Here's a patient I saw in 2018 who's got all the classic features of subclinical edema. These isopachs here, these are lines joining points of equal thickness. They're no longer circular. They've become straightened over here. The thinnest point of the cornea has been displaced nasally, which is not normal. It should be infratemporal. And you've got this area of focal depression here on the back surface. The back surface is displaced. So this patient has subclinical edema. But what I want to show you is 6 years earlier, the patient had a slightly different appearing map, but the telltale signs were there. There's nasal displacement of the thinnest point, straightening of the isopachs here, and just very early subclinical edema. So this can be a very sensitive tool to detect edema early. And just to show you how repeatable it is, that's 2019 and 2018 down below. They're pretty much the same. So it can be a very repeatable test. Here's another example where you've got obvious findings again. The three critical features are all present in 2018. But go back a few years, and this is even more subtle, but there is straightening of the isopachs, displacement of the nasal point. There's no posterior depression here yet, but it's all in the same place. The thickening of the cornea corresponds to where it was subtly thick 6 years earlier. Here's a patient, I didn't see them in 2020, but these were images that were captured where there's just subtle straightening of the Myers here. These should be circular. The thinnest point was also displaced nasally. And 2 years later, has more prominent changes in the same location, still has displacement, now has posterior depression. And I actually advised the patient at this time that they had a significant cataract. I advised them to have a DMEC with the cataract surgery, but they went back to their local surgeon who said, well, I don't see any edema, just have your cataract out. And this is what he came back looking like now, with quite obvious edema and a decompensated cornea. And the other eye had even more subtle findings in 2020, a bit more obvious in 2022, and I had said the same thing. You need to have a combined surgery, but his other eye also decompensated. So one more example of a patient in 2016 who's got a thin cornea, but has telltale signs present here. These isopachs are not circular, they're straightened here, and there's posterior depression. This worsens over 2 years. You've got an obvious area of focal depression, and another 5 years later, it's got more obvious signs. So this is a good test for finding changes over time. Why is this important and how is this relevant? When you have those features present, it is highly likely that your cornea is going to progressively get worse or progress to keratoplasty within the next 4 to 5 years. When your cornea does not have any of the abnormal features present, it is unlikely that you will progress to keratoplasty within the next 4 to 5 years, even if you go on and have cataract surgery. So this can be a good tool for differentiating who needs combined surgery or who just can get away with cataract surgery without keratoplasty. So it predicts prognosis. It also predicts vision. When you've got all three features present, your high contrast visual acuity is down. When you've got any features present, low contrast visual acuity, stray light, which is glare, also are affected. But when your tomography is normal, it's no different to age-matched controls. So normal tomography suggests that vision should also be normal, at least with respect to the corneal function. And here's a patient who was unhappy after cataract surgery with 20/40 vision, has all the classic features on the maps of subclinical edema that was not realized at the time of cataract surgery, had a toric IOL placed, and really needed DMEC surgery, after which vision quality was much better. The cornea was thinner, but nothing has been done to help their astigmatism. So when you've got abnormal tomography maps, then the back surface is not normal. You cannot predict toricity, and your back surface is aberrating the cornea, so avoid toric and multifocal lenses in that situation. So again, of clinical practical relevance. So again, structural imaging, I think great for research, but functional imaging, I think, is really becoming a standard of care. It's more helpful than getting endothelial images, and can really help you with decision making, and predicting vision and what you should do for these patients. Thank you.
Thank you, Dr. Sanjay Patel. That was an extremely interesting talk. I don't know how many of us are actually looking at the tomography when we are looking at Fuchs patients, but I think it's certainly something which, like you've shown, would be extremely useful. As we are nearing the end of the session, would the audience like to ask any questions from the two speakers?
I have a question to Dr. Sanjay. So you said that, so based on the tomography, you would decide whether it's a combined procedure or a staged. Is it only that, or even the symptoms of the patient? Because you said there was a patient who was okay with just undergoing the cataract surgery. So is it based on the symptoms of the patient that their vision is much more than the cataract per se, where you would advise? Or if you find that the cataract is significant to the vision loss, but the tomography is much more worse, so would you advise a combined surgery for it?
Yeah, you have to also, understand the patient's symptoms as well. So if the patient is symptomatic with their vision, they have a cataract present, but their tomography is normal, then I do not recommend combined surgery. I will just do cataract surgery and explain to them that the chances of needing a transplant are less than 10%, right, in 4 or 5 years. At the same time, you're going to see some patients, they're already pseudophakic, they have tomographic features present, but they'll say they're happy with their vision, they're doing fine, and I would leave them alone. So yes, you have to include patient symptoms in decision making.
Just to Dr. Janji, when you're looking at the lipid level with respect to LipiView kind of a thing, you sometimes have values which are even 100 and you have a very poor tear film. So there was a publication which they said that if there's a corneal staining, then you're not really estimating the correct lipid level. Also, even if you just address the aqueous phase either with the plugs and you do the lipid layer thickness pre and post, you seem to see an improvement in the lipid layer. So how much, are we trying to split hairs by individually trying to do it? Because ultimately it's the entire 3 layers which need to function in unison, one of which is going to affect the others.
Yeah, no, as I mentioned more than a couple of times in my presentation, that I rely completely on clinical exam and also the symptoms of the patients. I think there is no patient with MGD who does not have an aqueous component. The reverse might be true in some cases. In terms of, so if you've used LipiView, which I think you are using it, it's not an easy measurement. Patients have to stay still. And the eyes have to be really open. There are confounding factors. If a patient has even a little bit of conjunctival chalasis, you will get sort of a reading which can be all over the place. We have published at least 2 papers where we showed that if you do it properly, the repeatability is reasonably good. It's more than 87, 88%. But again, I agree with you, and that's why I said clinical exam takes precedence over anything else.
Because when you're looking at one particular value, it ultimately depends on how much the patient has blinked. If the patient has blinked about 20 times in that 20 second, your lipid value, if you're only looking at it at a value, the value is going to be much higher. If he has not blinked for the 20 seconds, the value will be lower. But the fact that he has not blinked tells you that the tear film is reasonably stable. That was one. Second was patients with chalasis, like you rightly said, even your TMH tends to get erroneously measured when you're looking at a keratograph to measure it, because it measures the film above it. So you will still have to rely on your clinical fluorescein that picks out that, okay, this tear film is above your conjunctival fold. So you need to kind of disregard that.
Absolutely. And I've seen that with keratograph especially. We use that more than other devices in our practice. So the reliability of these machines, again, it can be very user dependent as well. And as you mentioned rightly, that you really have to take everything into account.
So I think with that we'll come to the end of the session. Rightly summarized by I think all the speakers, clinical skills on top, and then a summary combination of all possible diagnostic devices that we have to get the composite picture. Thank you so much everyone, Dr. Bhaskar, Dr. Sanjay Patel, Dr. Vishal Jhanji, and Rashmi, and Dr. Nishant. And with that I think we'll close this session and let the next people take over. Thank you. I think we can have a group photograph first before we leave.